Welcome to This Week in Urology. This week we're covering 10 notable papers spanning advanced genitourinary oncology and biomarkers, localized prostate cancer treatment selection, and reconstructive, functional, and stone surgery. Let's dive in. We'll start with systemic therapy in advanced disease, where two large randomized trials landed in high-profile journals. In The Lancet, the LITESPARK-011 trial randomized 747 patients with advanced clear cell renal cell carcinoma who had progressed after anti-PD-1 or anti-PD-L1 therapy to belzutifan plus lenvatinib or to cabozantinib across 184 centers in 25 countries. At the second interim analysis, with a median follow-up of 29 months, the combination extended median progression-free survival from about 10.7 months to about 14.8 months, a roughly 30% reduction in the risk of progression or death. But, and this matters, overall survival was not significantly different. Median survival was around 35 months with belzutifan lenvatinib versus roughly 28 months with cabozantinib, and the confidence interval crossed 1 with a one-sided p-value of 0.061. Grade 3 or worse treatment-emergent adverse events occurred in about 84% of patients in each arm, with hypertension the most common in both. So this is a positive progression-free survival trial, with a currently immature and non-significant survival signal. The authors suggest it might become a new standard of care in the post-immunotherapy setting, but for now the honest framing to a patient is better disease control without proven survival gain and no toxicity advantage. Alongside that, European Urology published post-hoc subgroup analyses from the Phase 3 ARANOTE trial of darolutamide plus androgen deprivation therapy in metastatic hormone-sensitive prostate cancer. Among 669 patients, the benefit in radiologic progression-free survival held across every stratum, a 40% risk reduction in high-volume disease, a 70% reduction in low-volume disease, and 39 and 60% reductions in high-risk and low-risk disease, respectively. Secondary endpoints trended the same way, and treatment-emergent adverse events were similar between arms and all subgroups. The practical message is that low-volume, low-risk metastatic disease is not a reason to withhold treatment intensification. Turning to localized prostate cancer, where a major randomized trial and a long-term prospective cohort together complicate the story. In JAMA, NRGGU005 randomized 698 men with intermediate-risk localized prostate cancer to stereotactic body radiotherapy, 36.25 gray in 5 fractions, or to moderately hypofractionated intensity-modulated radiotherapy. At 2 years, there was no difference in the urinary, irritative, and obstructive domain. Roughly a third of patients in each arm reported a clinically important decline. Stereotactic treatment did look better on several other patient-reported measures. Fewer clinically important declines in the bowel domain, about 35% versus 44%. Better urinary continence at 1 and 2 years. Better sexual function at 1 year, and fewer grade 3 or 4 genitourinary adverse events, under 1% versus 2.5%. But the efficacy endpoint went the other way. 3-year disease-free survival was 92.1% with moderate hypofractionation versus 88.6% with stereotactic treatment, and stereotactic body radiotherapy was not superior. The trial did not demonstrate equivalent cancer control, and prostate-specific antigen failure was not improved. So 5-fraction treatment at this modest dose buys convenience and quality of life, and clinicians should be discussing that trade-off explicitly rather than assuming oncologic equipoise. Complementing that, BJU International reported 10-year oncological outcomes from the population-based CSER cohort of 2,604 men with clinically localized disease treated from 2011 to 2012. The headline is reassuring. 10-year cumulative prostate cancer-specific mortality was 1.5% or lower across all 5 strategies in the favorable prognosis group, including active surveillance, and progression did not differ. Overall survival appeared better after surgery than after external beam radiotherapy, brachytherapy, or surveillance, but the authors attribute that to residual confounding from baseline health and treatment selection rather than to cancer control. In the unfavorable group, again, no adjusted differences in cancer-specific mortality or progression. Read together with the JAMA trial. The message is that in favorable localized disease, the cancer rarely drives outcome. So comorbidity, values, and side effect profile should dominate the conversation. Staying with prostate cancer but moving to intraoperative and molecular staging, European Urology published a Phase 2 prospective trial of prostate-specific membrane antigen radio-guided surgery in 82 men undergoing robot-assisted radical prostatectomy with extended pelvic lymph node dissection, all with a nodal invasion risk above 5%. 62 patients completed all procedures. There were no adverse events from tracer administration and no intraoperative complications, and radio-guided surgery identified 2 additional node-positive patients missed by preoperative prostate-specific membrane antigen positron emission tomography. In men with molecular imaging node-positive disease, the per-region positive and negative predictive values were better than positron emission tomography alone. The important negative, though, is that the per-patient negative predictive value was only about 83%, not good enough to safely omit an extended dissection when the intraoperative probe is negative. So this is a tool for extending a template, not for skipping one. In bladder cancer, European Urology Focus reported on perioperative tumor-informed circulating tumor DNA in patients undergoing radical cystectomy and crucially examined whether it performs differently in pure urothelial carcinoma versus histological subtypes. Among 138 patients with preoperative testing, negative status predicted markedly better 2-year disease-free survival in both pure urothelial carcinoma, 89 versus 49%, and in histological subtypes, 79 versus 43%. Postoperatively, the separation was even starker, 81 versus 30% in pure urothelial carcinoma and 66 versus 29% in subtypes, with detectable circulating tumor DNA independently associated with a roughly 4-fold higher hazard of recurrence or death in every group. This is retrospective with short follow-up, but it supports using this biomarker for risk stratification irrespective of histology. Finally, the surgical and functional papers. In the Journal of Urology, a matched case control analysis compared 195 revision urethroplasties with 195 urethroplasty-naive controls drawn from more than 2,000 procedures, matched on age, stricture length, etiology, and technique. With a median follow-up of over 11 years, stricture-free survival was essentially identical, 91% at 1 year in both groups, and 83 versus 85% at 5 years, with no difference in 90-day complications, satisfaction, de novo erectile dysfunction, or CORD. The conclusion is that surgeons should not hesitate to offer revision surgery after a failed initial repair. On the stone side, the Journal of Urology pooled 20 studies and 2,326 patients comparing flexible ureteroscopy with mini-percutaneous nephrolithotomy for renal stones between 2 and 4 centimeters. Stone-free rates were statistically indistinguishable, but ureteroscopy was associated with shorter hospital stay, smaller hemoglobin drop, fewer transfusions, and roughly half the overall complication rate. Given the observational component of that evidence base, selection bias deserves caution, but ureteroscopy is a defensible primary option for larger burdens in appropriately selected patients. World Journal of Urology added an European Association of Urology and Urology systematic review of urethral calculi, 19 studies, 689 patients, most presenting in acute retention, showing stone-free rates above 94% across all modalities, no procedure-related deaths, and a practical threshold around 20 millimeters, separating minimally invasive from open management, with coexisting stricture a key driver of approach. And in neurology and urodynamics, a small randomized trial of 52 Egyptian women compared laparoscopic Birch colposuspension with transobturator tape. At 12 months, the failure rate was 34.6% after colposuspension versus 7.7% after tape, with worse symptom and quality of life scores in the laparoscopic arm and a roughly 7-fold higher odds of failure. Overactive bladder was more common after tape. With only 26 patients per arm, this is hypothesis generating, but it argues against colposuspension as a routine first choice where slings are available. If you only have time for one paper this week, make it the JAMA NRGGU 005 trial of stereotactic body radiotherapy, versus moderately hypofractionated radiotherapy. It directly changes how you counsel a very common patient. 5-fraction treatment improved several quality of life domains, but was not superior for disease control, and that nuance is easy to get wrong in clinic. Here are the key takeaways from this week in urology. First, belzutifan plus lenvatinib improved progression-free survival after immunotherapy in clear cell renal cell carcinoma, but overall survival was not significantly different, and toxicity was comparable to cabozantinib. Second, darolutamide's benefit in metastatic hormone-sensitive prostate cancer holds regardless of disease volume or risk, so low-volume disease is not grounds for withholding intensification. Third, in intermediate-risk localized prostate cancer, 5-fraction stereotactic radiotherapy offered quality-of-life gains without demonstrating superior or clearly equivalent cancer control, and 10-year cancer-specific mortality remains low across all strategies including surveillance. Fourth, prostate-specific membrane antigen radio-guided surgery can extend a nodal dissection template, but its negative predictive value is not high enough to omit one, while perioperative circulating tumor DNA robustly stratifies recurrence risk after cystectomy in both pure urothelial carcinoma and histological subtypes. And fifth, on the reconstructive and stone front, revision urethroplasty performs as well as primary repair, and flexible ureteroscopy matches mini percutaneous nephrolithotomy for 2 to 4 centimeter stones with less morbidity. That's your roundup for this week in urology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And if you have a paper you have been meaning to read, upload the PDF or paste any link at audioscholar.cc. We will turn it into audio like this one in any of 31 languages. This is an automated summary generated by artificial intelligence which can make mistakes. Always review the original source materials.